I'd like to welcome you to this month's Survivorship Rounds. I am Carmen Loisel, a professor at McGill University, and I will be the moderator for today's session. And I would really like to thank those of you who have joined us today, including those joining remotely. Today, we will hear from our speaker, after which we will open up the floor for discussion and any questions you may have. I'm very happy to introduce Mr. Barry Stein, who will be presenting on the patient's lives after the treatment and new priorities. Mr. Stein is an accomplished lawyer. He is the president of Colorectal Cancer Canada and also Coalition Priorité Cancer here in Quebec, an advocacy group. As one of Canada's leading cancer patient advocates, he actively represents the interests of patients and speaks regularly to healthcare professionals, industry, government, patient groups across Canada and internationally. Barry is also a survivor of metastatic colorectal cancer who had to seek healthcare outside of Canada to fight his disease. His judgment obtained in the Superior Court of Quebec serves as a leading precedent for the reimbursement of out-of-country healthcare expenses. We are delighted that Mr. Stein could be with us today. So, Barry, the floor is yours.
Well, good afternoon, and thank you so much, Carmen, for the invitation to present today. I hope I do you some justice in this presentation. And of course, my mouse is not working. There we go. So today, a little bit of a presentation overview. I will tell you a little bit about colorectal cancer Canada, about colorectal cancer in Canada, about who is a survivor, and I hope to tell you a little bit about myself at the same time. What is follow-up care and some survivorship challenges and solutions. So first, Colorectal Cancer Canada is Canada's national patient association. It's supported by a professional staff, expert medical advisory board, a national board of directors. And as I say, we are first and foremost a patient association. We're dedicated to some of the normal trilogies that you would have heard before: awareness and education, support for patients and their caregivers, and advocacy on their behalf. And our awareness campaigns, you can see a few of them on this slide, range everything from traveling the country coast to coast to coast with our giant colon, or some of the advertising campaigns that you've seen to encourage timely screening for colorectal cancer. And we do education both for the patient and the healthcare professional, and often do consensus statements together for guidelines. We provide support for patients as well as their caregivers, and we advocate in various areas. First and foremost, we advocated for bringing in the national screening, essentially colorectal cancer screening programs in every province. And we hope very soon to include Quebec in with all the other provinces in the population-based screening programs. We do primary prevention, and we have a program, as you may have heard of, called Foods That Fight Cancer. It's got a great Instagram site as well as great recipes. We do equal and timely access to effective treatments to improve patient outcomes, and that has a lot to do with health technology assessment and getting drugs into the hands of patients when they need it at the right time. So we aspire, of course, to reduce the incidence and the mortality of the disease and improve the quality of the life of our patients, their family, and caregivers. And we work in partnership with healthcare professionals, researchers, actually industry and government at the same time. And we have various resources which have enabled us to become leaders in areas such as patient values and preferences in cancer treatment. So a little bit about colorectal cancer in Canada. This year, according to the latest statistics from the Canadian Cancer Society, we anticipate having almost 27,000 Canadians who will be diagnosed with the disease. And that forms about 12% of all cancer cases, in the country. And of course, it includes men and women. Currently, about 50% of colorectal cancers are detected at a very late stage, that is stage 3 or stage 4, when it's very hard to prevent, not to prevent, but to cure. And of course, if we can find it early, we can remove polyps through colonoscopy. We can even resect the colon, and we can treat the disease so that we do have an increasing population of these higher stage patients. But of course, we want to catch them at a very early stage and prevent the disease in the first place. About 56% of these cases are expected to occur in Canadians who fall within the age between 50 and 74 years old. That's the highest. It really spikes starting at 50 years old. However, a large or an increasing, I should say, amount of the population, which included myself, who was diagnosed at 41 in 1995 with the disease, we see this population increasing at an increasing rate, faster than all the other subgroups. I'll get to that a little bit later, and you'll see some of the statistics around that. But about 1 in 14 men and about 1 in 18 women will develop colorectal cancer in their lifetime. And when I say colorectal cancer, that includes colon and rectal cancer. We commonly refer to it together as colorectal cancer. So a little bit about the age distribution of new cases, and you can see the incidence of colorectal cancer in young adults has increased between 2006 to 2015 with an annual percentage of 3.47% for men and 4.45% for women. And this is encouraged, as you may know, in the United States, the lowering of the screening rate from 50 to 45. We're not quite there yet in Canada, and we haven't really determined whether or not that's the best way to go and whether it's cost effective. You can see between the ages of 15 and 29, about 5% of all cancers are colorectal, 8% between the ages of 30 and 49 of all cancer cases. And then you can see the big spike starting at age 50. We target in Canada with our colorectal cancer screening programs with the fecal immunochemical test, those between the ages of 50 and 74. And we hope that we can reduce mortality if we can actually capture upwards of 60% of that population. We're not quite there yet. A little bit about the mortality from the disease. Unfortunately, this year we anticipate over 9,500 people, or 26 people about every day to die from the disease. About 43% of these deaths are expected to occur in those categories from 50 to 74 years old, and 4% are expected to occur among Canadians who are younger than 50. So mortality from the disease has actually declined slightly over the years and progressively since the mid-1990s, and we feel there's a strong connection between the stage at the diagnosis and survival. In other words, if we can catch people earlier, we can avoid and reduce the mortality. And interestingly enough, even at the death rate, it forms about 12% of the total cancer deaths in Canada. The age distribution, as I mentioned before, most people are over the age of 50 when they're diagnosed with the disease. But here you can see the distribution for mortality is very similar, actually, to that of the incidence. So about 5% of the total cancers between 15 and 29, and 11% between 30 and 49. And then the big spike actually happens over 50. And of course, people die not only from colon cancer, but from other diseases when they are above 74 years old. So when we start thinking about surviving from the disease, and there are more and more people who are surviving from the disease, Carmen mentioned that I am a survivor, obviously, of the disease, and that I was diagnosed in 1995 with metastatic colorectal cancer at a time where there was very little treatment options. I actually had to leave the country for my treatment, and the types of treatment that I received were chemotherapy, of course, resection of my liver, resection of my lungs, a vaccine treatment on an experimental basis, and some of the basic chemotherapies, originally starting with 5-FU, and with the addition through trials of irinotecan and oxaliplatin. But I also did a novel type of treatment by implanting a hepatic arterial infusion pump in my abdomen to give chemo directly to my liver. So I had not only these side effects that you will see from the treatment options that are in the screen in front of you, but I also had some additional ones resulting from the types of surgery, the types of treatments that I did receive at that time, such as the vaccine and the hepatic arterial infusion, which were in addition to the types of things you see here. So some of the side effects that patients will have as a consequence of their treatment will include pain, fatigue, of course, infections from surgery. That's a possible side effect. Sexual problems are a possibility. Scarring, ultimately from radiation, scarring and fertility issues. Incontinence is a possibility. From some of the basic chemotherapies, everything from diarrhea, nausea, mouth sores, poor appetite, changes to your skin, hand-foot syndrome, etc. Everything, including neuropathy from the oxaliplatin, or bleeding, brain bleeding, colon tearing from some of the targeted therapies, and some new side effects that patients are experiencing when they can get, and they do qualify for some of the new immunotherapies. But you'll see all through this some common threads, such as fatigue. This is a very big side effect from the treatment, but some of these effects will linger all through survivorship, including, for example, neuropathy from oxaliplatin. After having that for an extended period of time, patients may suffer that type of lack of feeling, or pins and needles, odd feelings in their fingertips and in their feet. Those are just a few of the examples. So who is a survivor? That's a good question. And when you're a survivor is also a good question, because many patients who are going through metastatic colorectal cancer may have periods of time when they've completed treatment and they have no evidence of disease. However, the classic definitions, as indicated by Winston Chung in his cancer continuum, are really once treatment has ceased. So once you've finished your treatment and you're not doing anything further, technically that's where the survivorship period begins. Some might argue, in fact, that as soon as you are diagnosed and you're still alive, you're a survivor. So these are just technical explanations. However, I think the classic one, when we're talking about it in terms of research and in terms of the types of programs that we could implement, would be following treatment, when treatment as a whole comes to an end. I'm showing you this slide on the survival rates from colorectal cancer because they're not so good when you're a stage 4 patient, as I was. You have to be lucky, you have to be aggressive, you have to be empowered, and you actually have to have a type of colon cancer that we haven't actually defined, one that is slow moving and can be chased. But you can see what the numbers are like in stage 3 and stage 4, where most people are diagnosed. The relative survival rate is going up, at least for the stage 3 patients, and it's quite guarded for the stage 4 patients. Nevertheless, this category of patients in stage 4, and there are many different types of stage 4 patients, is increasing as well. And we have to meet the needs of all of these people. It represents, in the United States, about 1.1 million people as of 2007. And if we do the classic divide by 10 for Canada, we could estimate probably today, this at any given time, although we don't have exact statistics, of about 150,000 colorectal cancer survivors in Canada. And it's likely to increase as we have better detection, better screening, and better treatment along the way. So, what are some of the positive effects of having cancer? And I like to say that along with the curse comes the gift. Well, some people may not take it to the extent where that I did in terms of starting and participating actively as a president and CEO of Colorectal Cancer Canada, but there are other side effects, or positive effects, pardon me, that people enjoy. And that is that as a consequence of realizing that life is quite delicate and may come to an end at any time as a consequence of your disease or any other reason, somehow some people develop an enhanced self-esteem. They have a greater appreciation of life. They may have heightened spirituality, great feelings of peace and purposefulness, and being more self-accepting, and maybe having a little bit more confidence in oneself because you realize you have nothing to lose. But those are just some of the positive effects. There's a host of negative effects as well that some patients may feel. Cancer-related distress, fear of cancer recurrence is probably one of the biggest ones. Adjustment to physical changes following treatment. Fatigue, as I mentioned before, is a big one. Sleep difficulties or lack of stamina. Pain, bowel problems, incontinence, sexual functioning problems, changes in relationships, self-esteem issues, decreased participation in activities, challenges returning to work, financial hardship, and impaired quality of life. I would say probably the biggest negative effect that I had was, of course, always being concerned about recurrence of the disease, but otherwise having an intolerance for people who talked about nonsense things. So that's something that I developed a great impatience for. So everyone may have their own variants to this list. But most people have at least one concern, and that could be depression, sadness, loss of interest in everyday things, anxiety, stress, worrying about the cancer returning, changes in relationships with family or partners, changes in relationships with friends or co-workers, changes in body image may be a possibility, particularly if from surgical scars and so forth, and changes in sexual intimacy. And this also could be enhanced for the patient who does have an ostomy at the same time. So you can see from this chart from CPAC and the Canadian Partnership Against Cancer in the transition study that colorectal cancer sort of runs parallel to what you would expect for all cancers. And the sort of category where there seems to be the highest concern would be in the stress or worry about the cancer returning. So therefore, follow-up for the survivor is one of the key factors. So colorectal cancer survivors and their loved ones continue to face challenges once the treatment is completed, and they need to be supported by the healthcare system. Colorectal cancer survivors are at risk for recurrence. A new primary cancer can happen. It doesn't always happen, and it's always a fear that you would have a secondary cancer. Short-term and long-term adverse effects of colorectal cancer and its treatments. A really good example from that, as I mentioned before, is in neuropathy, but also from radiation. There's a lot of side effects that may happen, including incontinence, which really causes a lot of problems for patients. Additional issues related to psychological, reproductive, genetic, social, employment concerns. Big factor in Canada, as you know, we're all concerned about the genetics, and we certainly believe in one of our programs called Get Personal about molecular profiling and genetic testing. So the question is, what is your right to privacy? Does this affect insurance? What is the effect, with respect to employers' rights and so forth? That case, as you may know, is under appeal, but we hope that the initial law passed in Canada finally will protect the individual's rights to privacy with respect to their genetic testing. So what about follow-up care? Well, there are various components of survivorship care. One is surveillance for recurrence or secondary cancers and the assessment of medical and psychosocial effects. 2, assessment and treatment of psychosocial and medical consequences of cancer and treatment. 3, management of comorbidities. 4, support for healthy lifestyles, prevention of recurrent and new cancers, and chronic diseases. One of the things that we focus on here at Colorectal Cancer is a program called Foods That Fight Cancer, where we have a full-time dietitian working on this. And this program, we believe, can help not only the prevention of the disease, but the recurrence of the disease. And we have partnered with several hospitals, including the Jewish General Hospital in Montreal, in their post-polypectomy clinic to demonstrate the value of these types of programs. And fifth, coordination of care between specialists and primary care providers for follow-up testing, such as blood work, CEA, carcinogenic antigen, or CT scans, etc. But are primary care providers ready for this challenge? I think is one of the biggest questions. So when we talk about coordination of care, the traditional model, of course, is the care by your cancer specialist or oncologist, but there are growing concerns over the cost effectiveness and sustainability. We have an increasing amount of cancer survivors or cancer patients in the country who need active treatment, and of course, in addition to the survivors who are increasing at an increasing rate in this country. There's a growing interest in shifting part of the survivor routine from the oncologist or the cancer specialist to the primary care provider. However, little is known whether follow-up care is best provided by the specialist or the primary care provider. I have to say there is increasing research and knowledge about this, and the survivorship handoff to primary care providers is not really something new, but it is something that's not properly done and done as intensely as it probably should be done. Primary care providers may give more preventative care and better address the chronic needs or chronic diseases, but may be unaware or unprepared for long-term complications of cancer treatment and may have limited access to the cancer center's medical records. And this is a huge concern. You'll see it demonstrated in some of the examples I give after. But we know, for example, in Quebec, that not everybody has an electronic health record, that certainly these health records from the hospitals are not linked to most of the primary care physicians, that even if they were linked, the primary care physician is not well enough informed as to the treatment of their patients over extended periods of time. So these are some of the complicating factors. However, a shared care model is where care is shared between the specialist and the primary care provider on completion of the therapy for the right patient, who is a low-risk patient, generally speaking. And the cancer specialist will provide a written treatment summary and survivorship plan to both the patient and the primary care provider. This is supported by ASCO and several other health authorities across the country. And I'll get into that a little bit later as well. But there has been a randomized trial. I believe it was Eva Grunfeld who did it in Nova Scotia, who found similar rates of serious recurrence-related events between the specialist and the family physician arms in this study. So we don't expect really to see differences if it's properly done in terms of the recurrence-related events. So who generally in Canada is in charge of follow-up care? It's interesting that in Quebec, you can see that 60.9% are mostly, the patients are mostly continued to be followed by the cancer specialist or oncologist. And in Nova Scotia, it would seem that there's most shared care than in the rest of Canada going on. And the most handoff care to the primary care physician seems to be in Saskatchewan. But I think all cases, we're trying to move towards at least the shared care for the appropriate patient in order to reduce the burden on the healthcare system. So some key considerations for the individual might be, are my needs being met and those of my caregiver? And what tools and resources exist for me and my physician to plan for survivorship? Are patients and physicians aware even of these resources if they do exist? And are they utilized? And will they continue to be utilized over time. For the healthcare system, we have to ask what's the current role for specialists in cancer centers versus the primary care physicians or providers in addressing the needs of survivors? And what should the role of the specialist continue to be in cancer centers versus those of the either general practitioner or primary care provider addressing the needs of the survivors? Do we have a capacity in our healthcare system to facilitate this type of survivorship planning? And what resources do we need to facilitate this planning? And finally, usually, probably the first thing I should have asked is it cost effective? So survivorship planning and integration with primary care ends up usually in something called the survivor care plans, or SCPs, and treatment summaries. And they communicate the survivor's health status, provide a care roadmap, if you will, to ensure survivor appropriate services, and clearly delineate who is responsible, which provider will be responsible, and for which aspect of the care. And various models have been developed and proposed to coordinate this follow-up between the specialist and the primary care provider. So generally the vision, which CPAC started to look into in 2009, made survivorship and survivorship care plans a practice of research and priority. So talking about this today, some 10 years later, we have to ask ourselves what progress has actually been made, and as I showed you in the previous graph, are we not properly handing off and applying the resources where they should be utilized? So the survivorship care plan, as I mentioned before, is really a personalized record of care and the follow-up that includes the potential post-treatment issues, signs of recurrence, guidelines for lifestyle modifications, and important community resources. Well, this all sounds great, and it'd be wonderful to have that type of plan for every patient that leaves, but who's actually going to fill that out? And do we have the time and the resources in order to enable and empower the patients to guide themselves by such a plan? The plan is dedicated to improve patient-reported and health-related outcomes after treatment has been completed and to reduce the survivor anxiety about what will happen after treatment is completed. And I would say one of the biggest factors that I have, of course, having been at high risk with metastatic cancer to liver and to lungs, I would say that I have very little desire to be handed off to my general practitioner. But that shouldn't be the case, because at this stage, many years later, since I've been not having evidence of disease, that pathway should have been created, and I probably could have been looked after by my general practitioner had he had the tools available to really understand what was going on in my previous treatment and to have the medical records, scans, etc., readily available. Survivorship care plans may be shared with the primary care provider to promote coordinated and ongoing care and improve communication between the survivor's cancer care team and the primary care provider. And you'll see shortly that that is one of the biggest problems, the lack of communication that exists. Some examples of survivorship care plans that do exist at BC, the BC Cancer Agency does have really probably some of the most effective resources in this area. I'm not sure to what extent they're actually being followed, but I have a couple of examples. But they do have, and you can download a very comprehensive survivorship plan that can be filled up. ASCO has a short one. The American Society of Clinical Oncology has a treatment plan, and a very interesting link that I found was OncoLife, where you can actually create a personalized plan yourself and provide a follow-up summary. So that's kind of fun, and that was developed out in Pennsylvania. So some of the challenges as we transition from active treatment to off-treatment status. As we transition from active treatment to off-treatment status, it's important in the long-term health of survivors. However, as I mentioned before, there's a great lack of communication and coordination of care during this transition period. And in the words of another survivor, I'm worried that my family doctor will not be able to provide the same quality of care that I receive from my oncologist. And this is a very common thread when we speak to cancer patients. Care varies widely between different centers. You may be at a community hospital, or you may be in some cases across the country in a dedicated cancer institution. Care expectations of the primary care provider versus the oncologist vary. There's a great lack of survivorship planning. Patients are at high anxiety, having had, particularly for metastatic patients, and there's a lack of resources for those patients who don't have a primary care physician, or as we call them, unattached patients. Patients may experience heightened needs coupled with the breakdown in the quality of care. For example, there may be deficiencies in managing healthcare due to various comorbidities, and these aren't always taken into account. And most of all, there very often is a lack of follow-up when this transition happens. So it's really important to empower the patient to really follow up themselves and ensure that their primary care physician is doing what they should be doing. But one of the most important things is patient selection, so that those patients that do go into a transition plan really are the right patients who are capable of their low needs. Their cancer comorbidities may be smaller, and they'll be most likely to do even better with the primary care physician and won't need the oncologist. However, when those are of high needs, in other words, they have a lot of side effects, for example, still, they may have to continue both with the oncologist and the primary care physician. And they understand that that's what the research is showing lately, that those who are at high needs or at high risk are utilizing both resources, and both resources more than the low need patients. So a couple of examples. I took a look at a paper from 2015 where they did interviews on improving coordination between primary care providers and oncology specialists as part of the CAN Impact study, the Canadian Team to Improve Community-Based Cancer Care along the continuum. I just chose 3 examples rather randomly from there, for no particular reason. This particular one, the Well Follow-Up Care for Colorectal Cancer Survivors and Their Circles of Care program, was a program started in 2014 as a result of extensive wait times for patients seeking active treatment. So this was necessitated by oncologists not having enough time to deal with those patients who required active treatment. And indeed, I think that that's probably, from a system perspective, where this big push is coming from, to ensure as well at the same time that there's excellent post-treatment surveillance for these survivors, and to enable their self-care and management. And a little underscore on the self-care and management, because not everybody could do that. We do need to, as I mentioned before, empower the patients and those patients who are capable of doing that. So in this case, the program was developed by medical and rad oncs and other oncology specialists, nurse practitioners, general practitioners in oncology, and general practitioners. So we really had they had really had a great amount of input there. And they developed a discharge to primary care provider model. They created it to reduce the follow-up care by medical oncologists and surgeons, increase capacity for patients needing active treatment, and ensuring at the same time access to high-quality care for the survivors. The discharge, how it went is they made a discharge appointment with oncologists to determine the patient's eligibility criteria, as I mentioned, lower need type of patients. And if they met the criteria, then a discharge letter was prepared for the patient, for the patient's primary care provider, and they met with an oncology nurse for their follow-up appointments and to receive educational materials so that the patient understood what was going on, and again, to self-empower them. And as they transitioned patients, they would give them a discharge package. So this would be a welcome letter to the primary care physician and a detailed discharge letter. They would also, and this was very important, create a receipt of information sheet, or in order that the primary care provider would sign off on it and undertake the responsibility to provide the follow-up care, and give them a toolkit as well with a surveillance protocol, secondary prevention measures, when to do the blood work, CEA testing, etc. And some of the lessons learned from this example was that the discharge visit had to be emphasized not only to between one physician and the patient, but the entire cancer center staff had to be aware of it. Again, a communication issue. And the receipt of the information sheet was necessary to ensure that in the community, the primary care physician or provider would really take on that responsibility, because they normally wouldn't have had that type of follow-up, which also brings to mind, will these physicians or providers have ample reimbursement for this additional workload, and can they accommodate that? And are there enough primary care physicians in order to take on that load? Also, with respect to electronic medical records, they required to have automated reminders so that we would miss, patients wouldn't miss their next test or their next follow-up blood work, etc. And that would help to facilitate the process of providing the follow-up care and conserve costs. But one of the problems that they found was that wasn't always well coordinated, and there was not great integration between the electronic health record systems. Another program in BC was the nurse practitioner program, which was quite interesting. It was a component of the BC Cancer Agency's Provincial Survivorship and Primary Care Program that aimed to provide primary care services to cancer patients and survivors who did not have a family physician. So we do know that there are a tremendous amount of Canadians that are unattached patients, and they still will require some sort of survivorship or follow-up care. And so how to do that? So their solution to that problem was by having nurse practitioners trained and located in primary care settings and provide the care and survivorship to these patients. They had three goals. One was to ensure survivors are attached to primary care and their primary care needs were met, and to address survivorship issues, the side effects, mental health issues, and so forth that I mentioned before, build capacity to support cancer patients, and increase time for oncologists to provide active treatment. So this common theme you can see building in at least the two models that I showed you is to really reduce the stress on these cancer centers and oncologists and increase time for those patients that really required seeing the oncologist for their active treatment. And some of the lessons learned from this was that the ideal setting was one where the nurse practitioner had the physical support and other nurse practitioners to partner with for collaboration, mentoring, and consultation. The program had to be better communicated with their cancer agency oncology staff to reduce uncertainty before and during the implementation of a program such as this, and that standardized tools to communicate this or to do knowledge transfer were needed. And there were barriers for these nurse practitioners to attain authority to access these various services. So they couldn't always access the medical records or the consult notes because they were not physicians. So these were some of the problems addressed, and I understand that many of them were overcome. And that's how they addressed the needs with respect to the unattached patient. Finally, just a third example. And again, there are many examples in the CAN Impact study that you can go to. I have the citation, which I'll show you following. The Juravinsky Cancer Center and their well follow-up clinics to facilitate transition of appropriate low-risk breast and colorectal cancer survivors from oncologists or specialty care physicians to primary care. So here I wanted this one. I thought it was important to show this one because it's important to identify the appropriate patient, the one who is at low risk, if it's going to work. And low-risk patients are those who do not have any significant ongoing issues with their cancer or their treatment. And here the programming was such that oncologists identified and referred the patients who are eligible to transition to these clinics, to the well follow-up clinics. They provided educational materials to empower, again, the transitioning patients. Patients visited, and I thought this was interesting because you can't just give a one hand off to anybody and expect them to understand everything, particularly in a sensitive time such as this transition time. So patients would visit the transition clinic 1 to 3 times, meet with the nurse practitioner to do a complete survivorship care plan and identify their personal ongoing needs. And they received a transition letter and their survivorship care plan before transitioning to primary care, and documents, or interestingly, still a fax to family physicians. That's something that I still can't get over, the fact that things still have to be faxed to family physicians. So some of the lessons learned are that it's difficult to relocate nursing resources, that there is a need to create awareness and increase understanding about this type of program, which still, even today, I think, even though that was in 2012, that even today it's not well understood, that there's an initial reluctance of oncologists themselves to transfer their follow-up patients to primary care. They may themselves not feel that the primary care physician is able to do this type of follow-up. And we need strong collaboration with family physicians, of course. So what are some of the future directions and strategies required? We need assistance for both the patient and the healthcare team in survivorship planning. We need better patient education and empowerment to reduce uncertainty at this very critical time. We need better communication and facilitation of handoff to the primary care provider and coordination between specialists and their providers, and optimization of resources and medical records so that the primary care physician or provider or nurse practitioner, whoever is going to do the follow-up care, will have access to the appropriate information at the right time. These are just some of the references. I was asked to make sure that we go through this slowly so that it could be recorded, and anybody who wants to have this will be able to follow up. I thought this was interesting when we talked about the different stages of colon cancer and mentioned that the most challenging ones for survival is in this stage 4 category, but certainly we're increasing all along the spectrum to understand what the different staging meant. What type of follow-up tests the patients may foresee. So we talk about the medical history and physical exam, the CEA test, the blood test, CT scans of the chest, abdomen, and pelvis, colonoscopy, and there may be other tests that go along with ostomy and ostomy problems. A little bit about the incidence and mortality rates, and some good news. I mentioned that they're decreasing, and here are the stats behind that. The reason for it, we believe, is due to increased screening, and the mortality rates are going down because the incidence rate is going down, and also because there are improvements in treatments. So that's the end of the presentation. Thank you very much, and I'm open for any questions that you may have.